Assalamu alaikum. I am Dr. Hafiz Zain, and the topic of my today's presentation is Open Surgical Management of Urolithiasis. And my moderator is Dr. Rabiullah. Introduction. Urolithiasis is a condition in which urinary stones are formed or located anywhere within the urinary system. The formation of renal calculi is a complex process, and it depends on the interaction of several factors, including urinary concentration of stone forming ions, urinary pH, urinary flow rate, the balance between promoters and inhibitory factors of crystallization, anatomic factors that encourage urinary stasis. There is a vicious cycle in urology: stone, stasis, and infection. If you want to eradicate any one of these, you have to eradicate all of them. Emergency. Renal colic, it is a sudden onset, acute, intense, agonizing paroxysmal pain which begins in the renal angle and radiates around the flank towards the bladder and testis in male and labia majora in females or to the anterior or lateral aspect of thigh. It is often associated with nausea, vomiting, and sweating. For example, in acute urinary retention and in calculus anuria. General recommendation is not to wait longer than 4 weeks for a stone to pass spontaneously before considering intervention. Large stones, usually greater than 7 millimeter, are unlikely to pass spontaneously and require some type of urological procedure. Such patients require mandatory urology follow-up. About 15 to 20% of patients require invasive intervention, eventually either as emergency or electively. Indications for surgery. The primary indications for surgical interventions are pain, infection, and obstruction. Interventions for urgent interventions are indications for urgent interventions are obstruction complicated by evident infection, obstruction complicated by acute renal failure, solitary kidney, and bilateral obstruction. The development of ESWL, URS, PCNL, laparoscopic robotic stone removal has resulted in a very few current indications for open surgical stone removal. There are a small number of patients who have extremely large stones with complex collecting system anatomy who may still be candidates for open stone surgery. These procedures are undertaken in portions of the world where aforementioned technologies or expertise are not available. Significant change in current management of urolithiasis, where the indications for open surgery narrowed down significantly, marking it as a second or third line treatment option. What are the principles of open surgery?
स्टोन्स हैं, solitary kidney with stone है, कुछ रिकमेंडेशंस होती हैं ओपन सर्जरी के लिए। और कौन है? फैज ओपन सर्जरी के लिए सब लड़ रहे होते हैं ना कि हमें ओपन करना है, ये करना है। ये तो इंडिकेशन हो गया ना कॉम्प्लेक्स एनाटमी। अक्सर हम ओपीडीज में भी डिस्कस कर रहे होते हैं, क्योंकि आपको ओपन सर्जरी के बारे में बुक्स में, लिटरेचर में कम ही मिलेगा। ये भी जरूरी नहीं है। बायलेटरल किडनी में अगर स्टोन्स हैं तो हम क्या कंसीडर कर रहे होते हैं? अक्सर हम मैक कराते हैं, फिर देखते हैं कौन सी किडनी बेटर है। जो सिम्टोमेटिक ज्यादा है वो हो गई। दूसरा और क्या होता है? इंट्रा ऑप क्या देखने होते हैं प्रिंसिपल्स। चलो आगे प्रोसीड।
Principles. The most important, to preserve as much as possible of the functioning renal tissue to prevent complications. Anesthesia may lead to decreased urine output after renal surgery in severely dehydrated patients. Thus, there is no place for hypotensive anesthesia in renal surgery.
तो कोई बता सकता है कि रीनल लॉस कितना होता है ओपन सर्जरी वर्सेस पीसीएनएल? एंडोस्कोपिक में तो चले कम है, लेकिन पीसीएनएल वर्सेस ओपन सर्जरी में कितना कंपैरिजन है? 5 to 10% है उसमें एंडोस्कोपिक में, लेकिन फिर भी इसकी एक्यूरेट नंबर देख लेना भाई। चलो आगे।
Special considerations. In bilateral kidney stones, operate the most painful side first and then to the other side. In bilateral kidney stones with one non-functioning kidney, operate on the healthy side first and then perform nephrectomy on the non-functioning kidney.
इसमें भी कुछ लोगों का वो होता है कि अगर पायोनेफ्रोटिक किडनी है एंड पेशेंट इज सेप्टिक और वो तो फिर यू शुड गो फॉर नॉन फंक्शनिंग किडनी. तो ये सारी चीज़ें रिलेटिव हैं, इसमें कोई एब्सोल्यूट नहीं है. ओपन सर्जरी वैसे भी ऑलमोस्ट तकरीबन ऑब्सोलीट ही हो गई है वर्ल्ड वाइड आफ्टर रोबोटिक और लेप्रोस्कोपिक, क्योंकि अब तो नेफ्रेक्टमी पायलोलिथोटमी सब कुछ हो सकता है इससे ना. लेकिन यू हैव टू सी ओवरऑल पिक्चर. ये नहीं है कि यहाँ लिखा हुआ है तो बस इसी को फॉलो करना है. आप कुछ पूछना चाहिए थी मिसाल. वही कह रहा हूँ ना, अगर वो पायोनेफ्रोटिक है या पेशेंट सेप्टिक हो रहा है बार बार, उसको रिकरेंट यूटीआईज हो रहे हैं, तो उसमें फिर आपको देखना पड़ेगा कि दूसरी किडनी अगर ऑब्स्ट्रक्टेड है तो आइदर यू शुड एटलीस्ट प्लेस अ स्टेंट, डीकम्प्रेस कर दें, उसके बाद फिर दूसरी किडनी को आप वो एड्रेस करें. लेकिन आइडियली तो यही होना चाहिए कि जो बेटर किडनी है उसको आप सेव करें, वो तो ऑलरेडी जा चुकी है. लेकिन अगर पेशेंट इज मोर कंसिडर्ड अकॉर्डिंग टू सिम्टम्स, फिर आप वो वाली किडनी को करेंगे. लेकिन आपको नेफ्रॉन भी तो प्रिजर्व करने हैं ना. अगर वो किडनी ऑब्स्ट्रक्टेड है तो आपको ये तो डीजे या पीसीएन जो भी है वो करके उसके बाद फिर वो.
Disadvantages of open surgery. There is more pain, bigger scar mark, longer wound healing time. There is more chances of infection, longer hospital stay, longer period before returning to work, and increased requirement for blood transfusion. The surgical management which will be discussed today will be nephrolithotomies, pyelothotomy, ureterolithotomy, and cystolithotomy. Here you can see the stones located in the renal pelvis, renal calyx, in the ureter and the bladder. Nephrolithotomy. An incision is made into the kidney substance to remove large stones. Hemorrhage is often severe. Perioperative. Orientation of the stone in the kidney is best defined with CT scan and three-dimensional reconstruction. If the patient does not adequately define collecting system anatomy, intravenous or retrograde pyelography is performed. Nuclear renography is performed if the involved kidney is thought to be functioning poorly. Antibiotic therapy is prescribed preoperatively if infected stones are suspected. Cross-match for blood is obtained and transfusion may be required. The utilization of sequential lower extremity compression devices to prevent thromboembolic complication is advocated. General anesthesia is administered and a Foley's catheter is inserted just prior to positioning. Positioning. The patient is placed in the lateral decubitus position. Cushions are placed along the spine, just below the axilla and between the legs. The patient is secured to the table with pads and white tape encircling the mid-chest and hip. Here you can see the position, lateral decubitus position secured by white tapes around the hip and the shoulder. Usually, the 11th and 12th supracostal incisions are usually used. The flank facial layers are opened and the diaphragm and the pleura are mobilized superiorly and the peritoneum medially. The utilization of self-retaining ureter is recommended. Here you can see different incisions. 12th rib supracostal incision, 11th rib transcostal, thoracoabdominal, flank subcostal, Foley muscle splitting, midline transperitoneal, subcostal, chevron incisions. Here you can see the layers of after flank incision. You can see that 11th rib, 12th rib, lumbar dorsal fascia, transverse abdominis muscle, internal oblique, external oblique muscles. Renal dissection. Gerota's fascia is longitudinally opened over the posterior aspect of the kidney. Perinephric fat is carefully dissected off the kidney, taking care not to enter the subcapsular plane. The ureter, renal artery, and renal vein are dissected out and encircled with vessel loops. Here you can see the Gerota's fascia and perinephric fat is dissected free, exposing the capsule of the kidney. A superficial incision is made along the parenchyma, overlying of the stone, and is further opened to expose the stone. The stone is manipulated out using the stone forceps. The nephrotomy may need to be enlarged, and the connecting system is incised further to deliver the branch stone without fracture. Other stones present are removed with forceps. Complete removal of the stone is confirmed with repeat imaging study. The renal capsule is closed with running 30 to 40 absorbable suture. A drain is placed posterior to the kidney and brought out through a small separate incision. The facial layers and the skin are closed in a standard fashion. Here you can
नेफ्रोस्टोमी डालनी चाहिए या नहीं डालनी चाहिए?
Here you can see the removal of the stones, nephrotomy. Postoperatively, the patient is closely monitored for vital signs and the signs of hemorrhage or renal insufficiency. The drain is typically removed when there is no indication of urine leakage or decreased output in drain, usually less than 30 ml. The patient is maintained on antibiotic therapy. Complications: hemorrhage, wound infection, urinary leakage, injury to surrounding structures, pneumothorax, atelectasis, and thromboembolic events. Now we will discuss pyelothotomy. Pyelothotomy is performed for presence of stones, for removal of stones confined to renal pelvis. Minimal dissection of the renal sinus is usually needed, and exposure of the entire kidney is usually not required. The procedure is not indicated for the removal of entrapped calyceal stones or large branch renal calculi. This procedure should be avoided if the patient has an intrarenal pelvis.
तो आर्टरी और वेन का क्या रिलेशन होता है पेल्विस से? एनाटमी अगर नॉर्मल बात करें, एंटीरियर से अगर आ रहे हैं तो वेन पहले होती है, फिर आर्टरी और फिर पेल्विस. सही है. तो ये चीज आपको सर्जरी में कंसिडर करनी चाहिए. और रीनल आर्टरी की एक और क्या खास बात होती है? एंड आर्टरीज होती है ना, तो आप जब भी डिसेक्शन कर रहे होते हैं तो जो आर्टरीज किडनी को जा रही होती हैं उनको बहुत केयरफुली आपने वो करना होता है. खासतौर पर जो ट्रांसप्लांट में है, जो देखा होगा, ट्रांसप्लांट में तो बहुत ही केयरफुली वो कर रहे होते हैं डोनर में. उस इवन कि आप पायलोलिथोटमी भी अगर कर रहे हैं तो कोई वेसल अगर किडनी को जा रही है तो उसको आपने स्पेयर करना होता है. ये नहीं कि आपने उसको लाइगेट कर दिया. चलो.
Perioperative evaluation and preparation are similar to those for nephrotomy. The kidney may be accessed through a flank, subcostal, dorsal lombardy, or midline incision. Exposure of the renal pelvis. Ureterus facies inside posteriorly, and the perinephric fat is dissected off the posterior surface of the kidney. The proximal ureter is isolated, and the dissection is carefully extended proximally, and posterior surface of the pelvis is delineated. Gilbert retractor is applied to expose the renal pelvis. This is the picture of Gilbert retractor. A U-shaped curvilinear incision is made with a hooked scalpel or a pot scissor with the lower extent at least 1 centimeter above the ureteropelvic junction. The stones are extracted with stone forceps, taking care not to extend the pylotomy. The technique of extended pylotomy can be used to obtain further exposure and facilitate stone removal. In this modification, the pylotomy is carefully extended superiorly into the respective infundibula. Inferior exposure can be enhanced by delineating the anatomic demarcation and making a small nephrotomy along the inferior edge of the kidney. Here you can see the U-shaped incision and the removal of the renal pelvic stones. Closure of the pylotomy and wound. Internalized ureteral stent can be inserted at the discretion of the surgeon. The pylotomy is closed with a running interrupted 40 to 60 absorbable suture. A drain is placed posterior to the kidney and brought out through a separate incision. Routine wound closure technique is employed. Postoperative care is similar to as described above previously in the nephrotomy. Complications are almost similar except there is a chance of secondary PUJO or proximal ureteric stricture. The posterior segmental artery can be injured during manipulation in the proximal portion of the renal pelvis and renal sinus. Urinary leak may develop and the patient is managed using standard approaches. Here you can see the closure of the pylothottomy wound. Now we'll discuss ureterolithiasis. It is useful. It is still useful in situations where endoscopic approach to the ureter is technically not possible, and the targeted stone is not amenable to ESWL or has failed ESWL. They are retroperitoneal, transperitoneal, and combined surgical accesses. It depends on the stone location. The location of a stone at the time of surgery is crucial, as the location of the incision will be determined by the location of the stone. For upper third of the ureter, a flank incision with or without rib dissection, lumbotomy incision, or subcostal incision, or supracostal incision may be used. A midline incision with intraperitoneal or extraperitoneal approach can be used if the patient has extensive prior retroperitoneal surgery. For middle third of the ureter, a Foley incision or a midline extraperitoneal incision may be useful. For lower third of the ureters, a lower midline incision with extraperitoneal approach is most useful. Gibson incision can also be used and it has the advantage of allowing access to the mid-ureter. A curvilinear incision 2 cm medial to the anterior superior iliac spine, infero-medially 1 finger breadth above the inguinal ligament to the lateral border of the rectus abdominis muscle. A fenestrial incision can also be used for distal ureteric stones. It is extremely important not to let the stone migrate from the operative field during the closure of the procedure, during the course of the procedure.
गिब्सन इंसिशन में किस चीज का ख्याल रखना होता है? नादिया, इंफीरियर एपिगेस्ट, उसको आपने स्पेशली आइडेंटिफाई करके उसको फिर लैगेट करना है, वरना वो एक दफा मिस हो गई तो फिर आपको रुलाती रहेगी सारी जिंदगी. ये इसमें भी लिखा हुआ है लैगेटेड एपिगेस्ट्रिक वेस्ट. चलो,
this is the Gibson incision. To begin, approach the ureter using whichever incision is deemed most appropriate based on patient's anatomy, stone location, and prior surgical history. In general, the dissection will take place in the extraperitoneal space. However, transperitoneal dissection can be used if necessary. Manipulate the ureter minimally during dissection to lower the chances of stone migration or ureteral devascularization. When the stone is located by visualizing a bulge or with the gentle fingertip palpation of the stone, secure the proximal control of the ureter with either a Babcock clamp or a vessel loop. The distal ureter is then controlled with either a Babcock clamp or vessel loop. 240 absorbable sutures are then placed on either side of the site of ureterotomy. Do not open the ureter until the stone is confirmed to be present at the site where you are giving the incision. The ureter is opened longitudinally over the stone with a hook blade. The incision can be extended using pot scissors. Once the stone is removed, the ureter is irrigated with normal saline proximally and distally using a rubber catheter to ensure that there are no remaining fragments. A stent can then be passed, although this is of a surgeon preference. Here you can see location of the after we located the stone, we applied the Babcock forceps and the proximal area and the distal area to control the to prevent the dislodge of the stones. You can see the incision given on the ureter, removal of the stone, and then the closure of the ureter. The ureterotomy is closed with interrupted absorbable sutures. A ureter is then wrapped in the adjacent periureteral fat. A drain should be placed. The drain should be close to the ureterotomy but not in direct contact. The incision is closed in layers with muscles reapproximation as appropriate. Complications. Sepsis is a risk of any stone manipulation, and the use of culture-specific or broad-spectrum antibiotics is important in the perioperative period. Prolonged drainage suggests distal ureter obstruction or ureteral devascularization and ureteral restructure. Now we will discuss the last topic, cystolithotomy. Stones that are too large to manage transureterally or endoscopically, and stones associated with prostatic hypertrophy should be removed by a suprapubic surgical procedure, which allows for removal of bladder stone and also concomitant prostatectomy. The patient is placed in a supine position. After prep and drape the penis into the field, insert a Foley catheter, and partially fill the bladder. Cover the penis with a catheter with a towel. After incision, push the peritoneal fold upward, revealing the perivesical fat. Through the Foley catheter, fill the bladder to the capacity with sterile water and apply retractor. Place 2 stay sutures in the detrusor wall above the pubic symphysis. Ensure that there is adequate suction in hand. Incise the
एक मिनट, कोई नए रेजिडेंट्स में बताएगा ब्लैडर कैपेसिटी कितनी होती है? R1 जो भी आए सबकी और फीमेल्स की, बच्चों की तो अलग होती होगी ना कैपेसिटी. पीडियाट्रिक ग्रुप में क्या होता है? इन्फेंट्स की और उसकी, इन सब के फॉर्मूला है ना, वेट को या एज को?
एज प्लस 2 into 30.
एज प्लस 2 into 30 होता है ना मेरे ख्याल से. इन्फेंट क्या होता है? हाँ, तो एज के हिसाब से और उसके हिसाब से होता है ना, फिर एडल्ट के हिसाब से कैपेसिटी हो रही है. ये सारी चीजें पता होनी चाहिए. आप सिस्टोलिथोटमी करने जा रहे हैं, बच्चे में कर रहे हैं, एडल्ट में कर रहे हैं, किस में कर रहे हैं, उसके हिसाब से आपने ब्लैडर भरना है. ये नहीं पूरी 1 लीटर नॉर्मल सलाइन आपने डाल दी, उसके बाद फिर आप वेट कर रहे हैं. चले ओपन सर्जरी के बाद चले कंटिन्यू.
Place 2 stitches in the detrusor wall above the pubic symphysis. Ensure that there is adequate suction in hand. Incise the detrusor muscle in a vertical fashion between the stay sutures and using electrocautery. Here you can see the incisions. Open the bladder enough to visualize the stones. The entire bladder not need to be incised. Use the suction to remove excess irrigation. Using the ring forceps, grasp the stone and remove it from the bladder. Where a large incision has been made, place suprapubic tube through a small cystostomy in the bladder and through the abdominal wall. Close the bladder in 2 layers using 3-0 vicryl on the mucosa and 2-0 vicryl on the detrusor layer. The mucosal layer is closed first with a running suture. Close the detrusor layer also using a running suture. Test the closure by filling the bladder with sterile water. Place closed suction drain near the bladder closure. Conclusion: although open surgery for treating urinary tract stones is rarely required at present, where most stone cases can be managed by minimally invasive therapy, we believe that it still has a role, and therefore it is of great importance to recognize that a small group of patients with complex stone disease and those with anatomical and physiological anomalies will benefit from these treatment modalities. Thank you.